Antiarrhythmic drugs. Right. For many of us in anesthesia, this whole topic can feel a bit like a maze, can't it? Full of complex mechanisms, confusing classifications. It's a lot to hold in your head. But what if we could build a really solid foundation, right from the very beginning, that makes it all just click into place? Well, in this explainer, that's exactly what we're going to do. We'll focus on the core electrophysiology and pharmacology you actually need to confidently manage these agents in your daily perioperative practice.
Hello, anesthesiologists. Thank you for your hard work today managing anesthesia for patients with arrhythmias. Starting today, we will thoroughly review the complex and often confusing antiarrhythmic drugs over the next 2 hours. Namaskar, anesthesiologists. आज अरिथमिया वाले मरीजों के लिए एनेस्थीसिया प्रबंधन में आपकी मेहनत के लिए धन्यवाद। आज से हम अगले 2 घंटों में जटिल और अक्सर भ्रमित करने वाली एंटीअरिथमिक दवाओं की पूरी तरह से समीक्षा करेंगे। Ekele, I want to talk anesthetic. We know just how challenging it can be managing a patient with a tricky arrhythmia right in the middle of a complex case. So our goal today is really to demystify the core principles, starting with the very basics of how the heart's electrical system works and, more importantly, how it goes wrong.
So, here's our roadmap for today. We're going to start by building the heart's fundamental electrical blueprint, quite literally one cell at a time. Then we'll see how the different cell types inside the heart create this surprisingly complex, heterogeneous environment. From there, we'll dive into the 3 main ways that things can go wrong and cause arrhythmias. Next, we'll pinpoint the specific triggers we face every single day in the operating theater. And finally, we'll connect all this physiology together, setting the stage to understand how our drugs actually work to fix the problem. Right, let's get into it then. To truly understand how any antiarrhythmic drug works, whether it's blocking a channel or tweaking a current, we first have to have a mastery of the normal electrical activity it's designed to modify. And that entire complex symphony of a heartbeat, well, it all begins with the action potential of a single cardiac myocyte. And here it is, the classic ventricular action potential that we all remember. It all kicks off in phase 4, the resting membrane potential. Now, this isn't a passive state at all. It's actively maintained at a very negative minus 90 millivolts. When the cell gets a jolt from its neighbor, we get this explosive phase 0 upstroke, a really rapid and massive depolarization. This is then followed by a brief partial repolarization in phase 1, which gives us that characteristic notch. Then comes the absolutely crucial phase 2 plateau, where the cell stays depolarized for a significant amount of time, allowing calcium to enter and the muscle to contract. Finally, phase 3 is the period of final rapid repolarization, bringing the cell all the way back down to its resting state. Ready for the next beat. Now, this is where it gets really interesting, because this table translates that shape into the language of ion channels. That stable phase 4 resting potential, it's set by 2 key players: the tireless sodium-potassium ATP PEMP, which maintains the ionic gradients, and a high permeability to potassium through something called the inward rectifier potassium current, or IK1. The explosive phase 0 upstroke is driven by the opening of voltage-gated fast sodium channels, causing a massive flood of positive charge. Phase 1 is a transient outward potassium current, or ITO. And that crucial phase 2 plateau is a very delicate balancing act between an inward calcium current through L-type channels, ICL, and opposing outward potassium currents, specifically the rapid and slow delayed rectifiers, IKR and IKS. Finally, phase 3 repolarization is dominated by these outward potassium currents as the calcium channels snapshot. You see, understanding these specific currents is the absolute key to understanding our drugs. But of course, the myocyte is only half the story. The cells that actually initiate the heartbeat, like the ones in the SA node, have a completely different looking action potential. You'll notice there's no flat, stable phase 4. Instead, we see the slow, spontaneous upward drift. This is diastolic depolarization. This is the heart's intrinsic automaticity. It's primarily driven by a unique current called the funny current, or IF, which flows through special HCN channels and allows a slow leak of sodium in. Once the cell drifts up to its threshold potential, the upstroke isn't driven by fast sodium channels at all, but by a much slower influx of calcium. This whole process is what allows the heart to beat all on its own. And this slide just brilliantly illustrates that functional divide in the heart. On one hand, you have the pacemaker cells. They're the leaders. They have intrinsic automaticity thanks to that unstable phase 4, a slow calcium-driven upstroke, and a less negative resting potential of about minus 60 millivolts. On the other hand, the working myocytes, they're the followers. They do the heavy lifting of contraction. Normally, they have no automaticity, a very stable resting potential down at minus 90, and that incredibly fast sodium-driven upstroke, which is absolutely essential for rapidly conducting the impulse across the ventricles for a coordinated, powerful contraction. Now, this idea of different cell types goes even deeper.
It's not just about pacemakers versus myocytes. Even within the ventricular wall itself, there's a crucial diversity that has profound implications for how arrhythmias start, and, as we'll see, how our drugs can sometimes make things worse. So, if we were to take a cross-section of the ventricular wall, we could actually identify 3 distinct cell populations based on their electrical properties. We've got the epicardial cells on the outer surface, the endocardial cells lining the inner chamber, and a unique group sandwiched right in the middle, known as M cells. Now, the key difference between them is the duration of their action potentials. It turns out M cells have fewer repolarizing potassium currents, which means their phase 3 is slower and their overall action potential is significantly longer than the other 2 cell types. Okay, so here is the crucial point. This difference in repolarization timing across the ventricular wall has a name. It's called transmural dispersion of repolarization, or TDR. Now, a certain degree of TDR is perfectly normal. It actually contributes to the T wave on the ECG. The problem arises when it becomes exaggerated by genetic conditions, electrolyte imbalances, or certain drugs. This creates a steep electrical gradient between cells that have finished repolarizing and those that are still lagging behind. This voltage gradient is incredibly fertile ground for life-threatening arrhythmias, particularly that polymorphic ventricular tachycardia we all dread, torsade de pointes. So we have this beautifully orchestrated, yet quite heterogeneous electrical system. How does it all break down and lead to the tachyarrhythmias we see in theater? Well, fundamentally, it boils down to 3 core mechanisms. The mechanisms of arrhythmogenesis really come down to 3 main culprits. First, you've got enhanced automaticity, where cells that are meant to be pacemakers just start firing too fast. Or even worse, cells that aren't supposed to be pacemakers start firing on their own. Second, there's triggered automaticity, where rogue impulses are sparked by the beat that came just before it. And third, we have re-entry, the most common mechanism of them all, where an electrical signal gets trapped in a feedback loop, circling endlessly and driving the heart at a dangerous rate. Now, triggered activity comes in 2 distinct flavors. You have early after depolarizations, or EADs, which occur during repolarization in phase 2 or 3. They happen when the action potential gets so prolonged that the L-type calcium channels have enough time to recover and reopen, causing a new depolarization. This is exactly why EADs are intrinsically linked to a long QT interval and are the cellular mechanism behind torsade de pointes. In contrast, delayed after depolarizations, or DADs, occur after the cell has fully repolarized during phase 4. These are driven by intracellular calcium overload, classically seen in things like digoxin toxicity or myocardial ischemia. The excess calcium is spontaneously released from the sarcoplasmic reticulum, causing a transient inward current that can trigger a brand new action potential. And finally, we have re-entry, the villain behind most of the sustained clinical tachyarrhythmias we deal with. Things like AVNRT, atrial flutter, and ventricular tachycardia. Now, for reentry to happen, 2 critical conditions absolutely must be met. First, you need an area of abnormally slow conduction, often caused by ischemia or scar tissue. And second, you need a unidirectional block, where an impulse can travel down one pathway but not the other. This combination, as you can see in the diagram, allows that slow-moving impulse to loop back around and re-excite tissue that has just recovered, creating a self-perpetuating, high-speed electrical circuit. This can be due to a fixed anatomical barrier, like an old infarct scar, or it can be purely functional, caused by dynamic changes in tissue refractoriness. Right, let's now anchor all of this fundamental science firmly in our day-to-day clinical practice. The perioperative period is a veritable minefield of potential arrhythmia triggers. We are constantly manipulating physiology in a way that can expose or create the exact conditions for these 3 mechanisms to flourish. Just think about a standard induction. The intense sympathetic surge during laryngoscopy enhances automaticity and can cause DADs by flooding the cells with calcium. Then you have intense vagal stimulation from surgical maneuvers, which can cause profound bradycardia, which in turn prolongs the action potential and predisposes to EADs. We constantly look after patients with active or potential myocardial ischemia, which slows conduction and creates the perfect substrate for reentry. We manage significant electrolyte shifts, and of course, the pharmacological agents we administer can directly impact every single one of the ion channels we've just discussed. This table is clinically vital, and it's really worth pausing on. Low potassium is particularly dangerous because it reduces the activity of that IKR current, directly prolonging repolarization and setting the stage for EADs. Hypomagnesemia acts in a similar way and also inhibits calcium channels. Conversely, hyperkalemia partially depolarizes the resting membrane potential.
This inactivates a portion of the fast sodium channels, which dramatically slows conduction velocity, a key ingredient for reentry, and can lead to conduction blocks, VT, or even VF. This is precisely why we are so vigilant about electrolytes. Correcting them is a primary antiarrhythmic intervention in itself. Many of the drugs we reach for every single day can prolong the QT interval. This includes our volatile agents, ketamine, high-dose opioids like methadone and sufentanil, our reversal agents, and even common antiemetics. Now, seeing this long list might be a bit concerning, but it's absolutely crucial to understand that not all QT prolongation is created equal. The real risk is actually far more nuanced.
So here is the crucial point, and perhaps the single most important message to take away from this explainer today. The real danger lies in drugs that increase that transmural dispersion of repolarization, the TDR. Our volatile anesthetics, for instance, tend to prolong the action potential duration homogeneously across all cell types. They block multiple currents, so while the QT interval gets longer, the TDR doesn't change much. However, drugs like ketamine and methadone are far more selective in blocking the IKR potassium current. And because those M cells rely so heavily on IKR for repolarization, these drugs preferentially prolong the action potential in the mid-myocardium. This dramatically increases TDR and creates that dangerous electrical gradient we talked about. This is what makes them far, far riskier in susceptible patients.
And with that, we've really connected the dots. We've journeyed from a single ion channel through the complex interplay of different cell types to the core mechanisms of arrhythmia, and finally, we've landed on the specific triggers and risks we face in the operating theater. We've built the physiological case for why arrhythmias happen. This foundation then naturally brings us to the next vital question. Now that we understand the mechanisms, the enhanced automaticity, the triggered activity, and the reentry, how can we use our drugs to specifically target and correct these abnormalities? How do we choose the right tool for the job?
Well, that is precisely what we will be covering in our next explainer. We'll take this physiological framework and use it to finally deconstruct the Vaughan-Williams classification system, showing exactly how each class of drug targets a specific part of the action potential to restore normal sinus rhythm. I very much look forward to seeing you there.